Good afternoon. My name is Dr. Clement Nuka. I'll be talking to you about septic shock. But before we get into septic shock, I'd like to compare it with cardiogenic shock. Cardiogenic shock, just for clarity's sake, so that we don't know, that we should know this is what we're talking about and we're not talking about that one. Cardiogenic shock. There are three factors that you have to worry about when looking at cardiogenic shock. You look at confusion because of inadequate perfusion of the brain, of course with blood. When you talk of perfusion, you think of blood getting into the tissue, into the brain. So the patient gets confused because there's inadequate perfusion of the brain. 2, the blood pressure goes right down, hypotension. The reason this happens is because the heart is failing. The myocardial tissue is not doing what it's supposed to do. The myocardium is not doing what it's supposed to do. In other words, pump the blood out of the heart. So the pumping ability has been compromised somehow. So that is why there's inadequate perfusion of the brain, inadequate perfusion of the other tissues. Now the other tissue the blood pressure goes right down. So hypotension, that's the second factor. 1 is confusion, 2, hypotension. Number 3 is oliguria. Oliguria, what is oliguria? It's reduced urine output. Because there's no blood going to the renal system. There's no blood going to the kidney. And that is why there's oliguria. So 3 things. 1 is confusion. 2 is oliguria. 3 is hypotension. That's because the heart is failing to pump. Now we get to septic shock. Septic shock is very different. Well, any shock, there's always inadequate perfusion. In other words, the blood getting to the tissues is inadequate, is insufficient. But now what causes that? What causes that? What causes that? What causes that is bacterial infection, very different from what happened in cardiogenic shock. There's inadequate tissue perfusion because of bacterial infection. There's abnormalities of oxygen supply. There's abnormalities of oxygen demand. There's metabolic changes, and the metabolic changes you think about metabolic acidosis, from metabolic alkalosis to metabolic acidosis. You don't want that. You don't want that. So metabolic changes. The last thing that happens, circulatory collapse. Oh no, this is bad. Circulatory collapse means end of life. I mean, really, if the circulation stops for whatever reason, circulatory collapse is a problem. So, but what causes this? I said bacterial infection. Which bacteria? Okay, when there's bacterial infection, the infected organ has got blood vessels. And then the bacteria, they get into blood. When the bacteria get into blood, we give this a special name to this infection or this now entry of bacteria into blood, that is given a special name. It's called bacteremia. So when there's bacteria in blood, that is known as bacteremia. Now, it is known that 25% of patients who have bacteremia will always progress to septic shock. And this is the problem. So the first thing that you want to know, the bacteremia is caused by what type of bacteria? And the only way of knowing is to gram stain those bacteria, gram stain them. If they're gram negative, it's either gram negative or gram positive. If they're gram negative, 25% of bacteremia caused by gram negatives will progress to what? Will progress to septic shock. Now, I'm sure we are interested in knowing what are they, when you say gram negatives, which gram negatives are we thinking about? I'm thinking of Escherichia coli, that is E. coli. I'm thinking of protease. I'm thinking of Enterobacter. I'm thinking of Klebsiella. I'm thinking of proteases, the Pseudomonas. The one that's so prominent in hospitals is Pseudomonas aeruginosa. And you've got this, and you've got one that is it's an anaerobe. It's an anaerobe. And when it's an anaerobe, what do you mean by an anaerobe? In other words, it exists in the absence of molecular oxygen, right? And this one is known as Bacteroides. And this one, these are the ones. Once you have these, you've got to go against them, that's for sure. Because you know that 25% of the patients will progress to septic shock. You've got to intravenous antibiotics. Which intravenous antibiotics are we thinking about? I'm thinking of aminoglycosides. Combine them with penicillin. But when you talk penicillin, use that language. Think of penicillin allergy. Those patients who have penicillin allergy, you've got to find out whether the patient has taken penicillin before and they have taken it well or what. Penicillin allergy should be your thing, you think about. So if you are then satisfied that the patient is not penicillin sensitive or is not allergic to penicillin, then you know that you're going to use penicillin. But which penicillin are you going to use? I'm going to use Carbenicillin. I'm going to combine it with an aminoglycoside. Which aminoglycoside do I have in mind? I have in mind amikacin, gentamicin, topramycin. So I take one of them and I combine it with carbenicillin. If I don't take carbenicillin, I can take ticagrelin. If I don't take ticagrelin, I can take piperacillin. Those will work, I can tell you. I just combine them with topramycin, combine it with amikacin, combine it with gentamicin. In the hospitals, the one of choice that's you find it in any hospital is gentamicin. Man. So if you have these, sometimes you get a situation where you've got staphylococcal infection. Oh, staphylococcus is gram positive. Which other gram positives do you normally get? Streptococcus pneumoniae, Streptococcus pyogenes, Streptococcus pyogenes. So these you need to make sure that if you get this, you must be cephalosporins. Think of cephalosporins. Which cephalosporins can you think of? I can think of cefazolin, can think of vancomycin, and think, or nafcillin. Nafcillin. Can use any of those just to make sure that the problem of staphylococcal infection is addressed. And so this is what you would do. But sometimes you want to snatch your patient away from the blazing, flames of circulatory collapse. You want to snatch your patient away. You can use chloramphenicol. Chloramphenicol, you use it so much, very much when you have this bacteroides, which is an anaerobe. You use that. But then, when you use chloramphenicol, you know that there's this problem of bone marrow suppression. Bone marrow suppression, come on. I'm going to use it because I want to snatch my patient away from the blazing flames of circulatory collapse, or inadequate perfusion of the tissues, or abnormalities of oxygen supply, abnormalities of oxygen demand, the metabolic changes. Metabolic changes I'm thinking about is what? Is a change from metabolic alkalosis to metabolic acidosis. The metabolic acidosis, we know that it will drive the patient to a coma, and a coma is a knock at death. You don't want that. So you're going to make sure that you treat these patients. And in fact, to go against the metabolic acidosis, I'm going to make sure that I give my intravenous bicarbonate solution. I'll give that bicarbonate solution to go directly against the metabolic acidosis. Then we can have a situation where you find that, hey, this thing persists despite the fact that I've given my, all these, and then you find that it persists. And then in that case, you have to think of vasopressors. Vasopressors like what? Vasopressors like dopamine. Dopamine, I know dopamine will be able to make sure that the brain is well perfused. The renal system is well perfused, so that I don't get this oliguria, which is a problem, right? So I give my skin is well perfused, that my kidney, my liver is well perfused. Remember, there was hepatic dysfunction. And because of this inadequate perfusion of these tissues, right? So I will need, my kidney will be well perfused now, and so I won't get any oliguria, and my liver will be well perfused if I give dopamine. And the liver as well. And man, you know what are the complications of septic shock? Complications, very complicated. You get what is known as DIC, disseminated intravascular coagulation. You can imagine clots all around the body. Oh no. And then that will give rise to renal failure. That will give rise to actually kidney failure. That will give rise to what? To heart failure. How will you know that there's renal failure? Renal failure, of course, we look at that oliguria, that oliguria that reduced cardiac, reduce urine output. And how will you know that there's now it's complicating to become a heart failure? How will you know? Edema, shortness of breath, edema. Those will be giveaways to say that the patient is now having a heart failure, and as a complication of septic shock. Right. So basically, this is what we need to be understanding, and we have to all the time. We have to just to make sure that the problem of when we want to summarize this, we say, how is it different from cardiac shock? Cardiac shock is different in that cardiac shock, just confusion, just hypotension, and just oliguria, which is reduced cardiac, reduced urine output. So that would be some. It goes to an extent sometimes of when is this really kidney failure, of getting anuria, you know. So this is you know. So, but then, which are the other complications? Complications of DIC, I say, heart failure, renal failure, you know. These are the complications, and this is what you don't want to see. And these are reversible. You can reverse this. And a situation when we must always have in mind that the etiological agent or the causative agent is actually infection. If it's infection, then you have to go against that infection by doing what? IV antibiotics. IV antibiotics. What do you have? You must have gram-negatives first. What gram-negatives? Because gram-negatives, they easily form septic shock, right? And then gram-negatives. What are you thinking about? I'm thinking of IV antibiotics. I will always give. I'll give I'll make sure that I give carpenicillin for gram-negatives. I'll make sure that I combine it with gentamicin or tobramycin or amikacin. I'll make sure. If I don't have carpenicillin, I'll use ticagrelor. If I don't have ticagrelor, I can use piperacillin. You know, and that's that. And then if I suspect any staphylococcal infection, then I know that I have to use my cephalosporins. Cephalosporins that are of choice, cefazolin, and then vancomycin or nafcillin. I can use those. Make sure that I give them intravenously, and tell you, to snatch the patient away from the blazing, flames of circulatory collapse and inadequate perfusion, tissue perfusion, and the abnormalities of oxygen supply, and abnormalities of oxygen demand, and circulatory collapse. To make sure that I snatch the patient away from that, I'm gonna make sure that I give my chloramphenicol. Even if it causes bone marrow suppression, doesn't matter. I'll snatch them away from circulatory collapse. Even if I'll use my clindamycin, even if it causes whatever it causes, pseudo membranous enterocolitis, it doesn't matter. I will use it to go against, to try and snatch my patient away from the blazing flames of circulatory collapse. This is something that you find only in septic shock. You don't find it with the cardiogenic shock, right? So basically, this is what we need to be understanding and need to take all the time, and make sure that if, for instance, the septic shock persists, if it persists, make sure that you give your vasopressors anything that will suppress, that will make sure that the brain is perfused. The brain is perfused, the kidneys are perfused, and the liver is perfused. The liver is perfused, and then to make sure that perfusion is proper, it's got to be proper. And then those the dopamine is number one in that, in making sure. Dopamine is number one when it comes to that, to make sure that all the systems are. You must remember that you can't afford to have a kidney that is not perfused. You can't afford to have a skin that's not perfused. You can't afford to have. There's no way you can't afford to have you must always have in mind that the complications of septic shock, like DIC, disseminated intravascular coagulation. Make sure that you understand the renal failure as a complication. Make sure that you understand the heart failure as a complication of septic shock. That is why you have to go vigorously against this by using IV antibiotics. And the IV antibiotics of choice have been enumerated, and we know that we will always give my IV bicarbonate solution to go against metabolic acidosis. And that you will always make sure that these are done. And I can tell you, you'll have had a situation that would have been disastrous otherwise. If you didn't do that, you would get a situation where you get circulatory collapse, you get abnormalities of oxygen supply, get abnormalities of oxygen demand, you get inadequate perfusion of the tissues in general, you get changes, metabolic changes, and this is something that you should make sure that it doesn't happen. And all the time have in mind that the type of gram negatives which would like Enterobacter, protease, like Klebsiella, like E. coli. Like make sure you know some of these, like Bacteroides as an anaerobe. It's capable of living in places where there's minimal, in fact there's no molecular oxygen, and you are going to use, for instance, Bacteroides, you must have your chloramphenicol here next. Even if it causes moral suppression, doesn't matter. You use that to make sure that you suppress it. And this is, if there are any questions as far as this is concerned, please make sure that you understand and you follow the differences between cardiogenic shock and septic shock. In a septic shock, we are talking of nothing else but bacterial infection. In bacterial infection, you think of gram negatives and gram positives. Sometimes you do get bacteria, you do get viruses, which, and in the rickettsias, the blood, you got the rickettsia, the chlamydia, they actually, they can complicate in becoming a septic shock. So you need to be able to get this right. Chlamydia trachomatis, for instance, chlamydia pneumoniae, all these, you need to go against them, just to vigorously against them, to make sure, aggressively against this, so that as long as you have your counter, as long as you have your counter, of course, you must have, if you don't know whether the patient is sensitive to penicillin, you must always have your allergics to make sure that you go against any, maybe give, by mistake, you give penicillin, you give penicillin like capenicillin, or ticagrelor, or you always give it piperacillin. You give it together with what? You always give it together with an aminoglycoside. The aminoglycosides of choice is amikacin, topamycin, gentamicin. In hospitals, we've got a lot of gentamicin, right? So make sure that you aggressively go against bacterial infection. Thank you very much to make sure that there's no septic shock. Thank you very much.